Hello and welcome everyone. It's good to be back once again, and today we have another special guest. As you can see, Dr. Esther Marbán is right here with us. Hello, how are you feeling? It's so great to have you back once more with this amazing topic, that's for sure. Thank you so much. And how are you?
Hi, Caroline. I'm really glad to be with you once again, and I'm really happy to speak about this topic this night.
We are definitely looking forward to it. This is definitely an interesting topic. And as always, of course, Dr. Marbán has prepared a presentation on endometrial receptivity, immunology, and also microbiome. So she will explain everything in her presentation. But afterwards, remember, it will be time for your questions. Don't hesitate, type those in the chat section, and I'm sure she will be happy to help you out with that as well. And as you know, we have over 300 IVF webinars so far, so you know there are plenty of topics that we already discussed, and I think that when it comes to endometrial receptivity or immunology, this is always a topic that brings lots and lots of questions. So remember, you can type those in during the presentation, but also afterwards, so go ahead and do it. And well, now I think it is time to start our presentation. Okay, Dr. Marbán?
Okay.
Thank you so much. And also, I just wanted to remind everyone, if you haven't seen Dr. Marbán in action yet, I just want to mention that she's the specialist and gynecologist at Clinica Tambre, which is located in Madrid. So she has been with us before, and I'm very, very happy to have you back for sure. Thank you so much, and let's go ahead with the presentation.
Thank you. Okay, so hello everyone. So as you already know, today we are going to talk a little bit about an endometrial guide. So we'll talk about receptivity, microbiome, and immunology. So here you may see what will we cover. So first of all, we will talk about the definition of endometrium and its importance. Then we will talk about the endometrial receptivity, endometrial microbiome, endometrial immunology, and we will give you some conclusions. So what's endometrium? The endometrium is the innermost layer of the uterus where the embryo, implantation, and the fetus development takes place. Due to the ovarian hormones, the endometrium changes every month. So we know that the estrogens produce the lining thickened to prepare for a potential pregnancy. The estrogens are produced by the ovaries. The same happens with the progesterone that prepares the endometrium for the pregnancy, supplying the lining and stimulating the glands to grow to nourish the early embryo. But oops, here we are. I think the presentation is going a little bit slow. Okay, so here we are. So why is the endometrium so important regarding the fertility treatments? So it's important to know that the endometrium is the place where the embryo plants, as we mentioned before. So a good endometrium is connected and is related to higher pregnancy rates. Apart from that, we need good thickness and a triple line aspect in the endometrium to achieve better chance of implantation. So that aspect could be achieved in different ways. So when we do an IVF cycle, when we stimulate the ovaries, secondly, the ovaries produce estrogen that will affect the endometrial lining and will make it be thicker. So apart from that, we can also use a natural cycle in which we don't need to use any specific medication at the first part of the cycle to make that endometrium be thicker and to be ready for the eventual implantation. So when we are talking about freezing, well, actually doing transfer with frozen embryos, we are quite used to use like natural cycle, trying to have the endometrium in the best conditions. Apart from that, some other patients need or prefer to use estradiol and progesterone to make the endometrium be in the best condition, which is a quite common treatment also used in frozen embryos transfer. And some other patients, very specific patients, a small group of patients may need other therapies such as gonadotropins, aspirin, or even other treatments trying to make that endometrium be thicker. But in general, most patients don't have many issues with the preparation of the endometrium, and with a natural cycle or normal treatments is more than enough. Okay, so let's start from the beginning, and let's start talking about endometrial receptivity. So the window of implantation is known as the period of time when the endometrium has the best conditions for the embryo implantation. So once we find that moment, we talk about that endometrium is receptive. So this period is short, depends on the effect of estrogens and progesterone in the uterine lining, and varies between women. So normally, that window of implantation is placed around 5 days after adding the progesterone in many patients, and around day 19 and 21 in a natural cycle. But not all the patients may have that window of implantation in the same place. Actually, it's known that around 30% of patients may have the window of implantation displaced. There are some tests that may test that kind of issues, and the most known is called ERA, that stands for Endometrial Receptivity Analysis. It tests 248 genes involved in implantation, and it's just necessary an endometrial biopsy in a more cycle, and it doesn't need to be taken in any kind of surgery. It can be taken in the consultation. So what we normally do is we prepare the endometrium with a natural cycle, or even with medications such as estrogens and progesterone, and we try to do exactly the same that we will be doing in the eventual next embryo transfer. So in that moment, we take a small sample of the endometrium in the consultation, and we test specifically that window of implantation. So after we have the report, we can personalize the eventual embryo transfer. As we were mentioning before, some patients may have a different gene expression, that may affect the window of implantation and endometrial receptivity. So that test may help personalize the embryo transfer moment. So if we find that, for example, one patient needs some less hours of progesterone, we can do exactly that way for the next embryo transfer to try to increase the implantation rate. So who could ERA be useful for? So we normally recommend using ERA for patients with several unsuccessful good quality embryo transfer, patients with previous unsuccessful euploid, which means chromosomically healthy embryo transfer, and patients with thin endometrial lining. In general, it could be also recommended for patients who want to have a better approach on their endometrium before transferring their embryos. So it's a quite useful test, and we use it quite often in our medical practice. Let's talk then a little bit about the endometrial microbiome. So the endometrial microbiome is known as the totality of microorganisms in the endometrium. The normal microbiome is dominated by lactobacilli species. So we know that a normal endometrium has to have a quite high percentage of lactobacilli species inside it. So pathogenic deviations in the dominant microbiome may play a role in infertility. So a normal endometrial microbiome has been associated with implantation failure, pregnancy loss, and adverse obstetrical outcomes. So in this slide, you may see different columns. In the first one, you may see how the proportion of lactobacillus species, which is drawn in blue, is dominant. And in that kind of patient, in that group of patients, they had a good pregnancy outcome. So they had a baby at home. we compare with the ones that didn't have that good outcome. So in that patient, that there is no the main species in the endometrium is not the lactobacillus, it's not dominated by that lactobacillus species. The outcomes during the pregnancy were not so good. So the second column is the miscarriage and the implantation failure in the end. So it's really important to have that kind of species inside our endometrial. Otherwise, we know that the results could be not so good. So there are some tests that may help us in that kind of issues. The most known is called ALICE and EMMA. ALICE detects bacteria causing chronic endometritis, which means that it's a long-term inflammation of the endometrial tissue caused normally by an infection, and EMMA tests the endometrial microbiome. So the idea is that both tests may provide very useful information on the endometrial bacteria, which could be of a higher importance for our medical practice. So in case an infection or a microbiome alteration is confirmed, an accurate treatment will be recommended. So we normally perform both ERA, EMMA, and ALICE at the same time. So the idea is like taking that small sample that we were talking about previously to test all that issues and trying to have a really good approach on what's going on the endometrium. So if we find that the patient has any alteration in the microbiome, we normally recommend using some antibiotics during 1 week, 10 days. It depends on the bacteria that is causing the problem. And then it's recommended to use some probiotics, vaginal probiotics, to try to to have that lactobacillus back in the endometrium and have like a different, in the end, have a better chance of implantation of the next embryos that would be transferred afterwards. So the same that happens with the ERA, we recommend EMMA analysis in patients that have a failure of implantation diagnosed, and also for patients that in general want to have a better approach on the endometrium before transferring the embryos. So it's quite common to find patients in our consultation that have tried several times, and we normally recommend doing like quite complete examination of the uterus, trying to have the best information regarding that, and also be able to add any small specific treatments in case it's needed to be that way, of course. And so let's talk a little bit about the endometrial immunology, which is a quite interesting topic, but it's also not so good known in the end. So research suggests the immune system, cells such as natural killer cells and lymphocytes may play a role on the reproduction ability and the maintenance of the early pregnancy especially. So the NK cells endometrial testing with an endometrial luteal phase biopsy may help identify women at risk of implantation failure or recurrent miscarriage who may benefit from a specific treatment. Immune testing and treatment is not required for most patients. This is something very important to know and to clarify, because most patients won't need to have that test done, and actually they won't need any specific treatment regarding that. So that test could be requested in patients with failure of implantation or recurrent miscarriages where no other causes have been identified, and when embryonic factors have been previously ruled out. So more research is needed to prove a definite link between alterations in the NK cells and adverse reproductive outcomes, as well as to confirm what treatment would be of benefit. So in the end, we normally prefer to try to be focused in the treatments and the tests that have been proved that may help us, because of course immunology, it's not that of course it may help us in general, but that kind of tests are really specific and they have to be requested in a very specific group of patients. So it's not recommended for all the patients. So to give you some conclusions and the ideas I would like you to take home. So as we mentioned before, the endometrium is extremely important for fertility treatments. A good endometrium may increase the implantation rate, but apart from the basic examination with a vaginal ultrasound, it's currently possible to have a better knowledge of the endometrium function and receptivity with several endometrial tests, as we have been talking about them before. So our main goal is always improving the reproductive outcomes. And thank you very much for your attention.
Wonderful. Thank you so much for, again, explaining all those details. And well, now it's definitely time for our questions. And I believe you see that there are plenty of questions. So I guess we can definitely go straight to them because I think the first question even showed here when you just started the presentation. So as I mentioned, this topic definitely brings lots of questions. So let's get to the questions. Okay. Let's have a look. The very first question we have from Margie. So is the biopsy of ERA painful? How long does the procedure last? Thank you so much for the first question.
Okay, so thank you for the question, Margie. So, well, the biopsy itself is not very painful. Of course, we need to take that small biopsy, and we use like a very thin catheter to go inside the uterus. It's a bit thicker than the one that we use to do the embryo transfer, and normally it's not painful. So it's just like, I would say that it's not very nice to feel that, well, to do it, but it's not painful itself. So it's a quite short procedure. It lasts for maybe 10 minutes. But of course, it always depends on how difficult is going with the catheter inside through the cervix and going inside the cavity. So normally it takes like 10 minutes maximum, but of course it depends on each patient, and it's not very painful itself.
All right, perfect. Thank you so much indeed for explaining that. And we have more questions on ERA test. So let's get to those. What is the success rate of transfer after ERA test?
Well, of course, it depends on other factors. It's not just having an ERA test done. So, well, it's supposed that it may increase the implantation rate. Of course, we need to clarify that we are always talking about, other like issues, like, for example, testing the embryos, doing the PGS on the embryos, and being sure that the embryos are euploid, are healthy. So in that kind of embryos, ERA test could increase like the implantation rate around 20% of approximately 20%. Of course, it always depends on other factors, but well, we know that it's important to personalize the embryo transfer. As we mentioned, around 30% of patients could have that window of implantation in a different place when it should be. So in the end, we are able to have that information. Of course, it would be like very important for us to personalize that next embryo transfer.
Thank you once again, of course, for yet another question. And again, more questions on ERA test. So let's go to those first. Okay. So first of all, this is how long is the ERA test valid for? Can it change from 1 year to the next? And just give me a second. I will show you. Yeah. Oh, okay. There's another question. Yeah. Do you need to repeat the ERA test?
Regarding how long the ERA test is valid, it's normally valid for around 2 years. But of course, it depends on the conditions of the patient. So normally, if the ERA test is fine, it doesn't need to be repeated. So when the ERA test says that the endometrium is post-receptive, it means that the window of implantation has gone. So we normally need to do another mock cycle and repeat again the endometrial biopsy some hours before we took the first one to try to clarify exactly when the window of implantation is. So when the endometrium is receptive or even pre-receptive, we know that we need to do the embryo transfer in a very specific moment, but when the window of implantation has already passed, it's impossible to know how many less hours of progesterone that patient may need, and that's the reason why we need to repeat the ERA test. But normally, it's not needed. Like I would say that more than 80% of samples are fine and don't need to be repeated again.
And thank you so much for yet another explanation. And let's me have a look. Okay, I guess now we will go to Emma and Alice test. Okay, so let's have a look at this one here. Do you need to do a cycle to do Emma or Alice test like Ira?
Actually, you don't. So if you have like regular cycles, you don't need to add any specific medication, and the laboratory just recommends taking the sample between day number 15 and 25 of your cycle. Okay, so if the patient has like regular cycles, it's quite easy to know exactly when we need to take the biopsy of the endometrium. So it's not recommended, well, exactly, it's not needed to use a specific medication unless the patient has no, well, it's not menstruating. I mean, if the patient is in amenorrhea, of course, we need to add like estrogens and progesterone to make that endometrium be thicker. Otherwise, it's not needed. So just calculating when, well, the moment for the endometrium is, and we just need to take that sample in that moment, and it would be more than enough.
Thank you for explaining yet again, of course, this one, and actually more questions on Emma and Alice. Okay, so Alice and Emma need to be on a certain day, on the certain day when not doing
exactly between, like, it's like in a almost in a luteal phase between day 15 and 25 of the cycle. So it's just a matter of counting when the menstruation starts and counting those days to calculate when would be a moment for the Emma and Alice to do the test.
All right. Thank you for the confirmation to this one. And now let's go to this question. So what test do you do for microbiome and pathogenic? Not sure.
Well, I guess that that refers to, well, the other bacteria. So the test is always performed in the way that we know exactly the proportion of lactobacillus that the patient has. And also the recommendation regarding the proportion of the lactobacillus, the laboratory tells us if it's like enough, or if the patient needs to use some probiotics, trying to have like a higher proportion of lactobacilli species inside the uterus. And also the other test which is performed is like they test the other bacteria, the pathological bacteria that may also be inside the endometrium, and they like specify what kind of bacteria the patient has, and also the recommended antibiotic therapy that the patient should use. So we have like all the information, and we have like a complete report with all the important information for us.
Perfect. Thank you so much once again, of course. Okay, and the question is, so what is the red part in microbiome graph?
Oops. Let me check it. The red part. I guess that, of course, I think it's like one of the most common bacteria, which is, I think, is like the. Let me. Maybe we can.
Presentation, right?
Yeah. Let me. I think it's like one of the. We can go back. So it's one of the. Okay, so is one of the most common common bacteria that we normally find in that sample, which is like the Gardnerella. Gardnerella is like a bacteria which is normally in our vagina, and it's quite common to find it also in the endometrium. Okay, so I think it's like, well, this is the Gardnerella. Yeah.
Okay. Excellent. Thank you. And actually, someone added what's column 3.
Sorry?
So the next question is actually in regards to your presentation as well. Yeah. So what's column 3? I'm not.
Yeah, the column 3, I think, is like the failure of implantation. Yeah.
Okay.
No, sorry. The second one is the failure of implantation and miscarriage, and the third one is the patient that didn't get pregnant at all.
Okay. All right. Thank you for the clarification, of course. And let's go back to the questions and let's have a look at the next one. Okay. So how long does it take to improve the microbiome of the endometrium?
So normally it's recommended to, in case we don't find like a good, the dominant bacteria, which is not the lactobacillus, normally it's recommended to use some probiotics, vaginal probiotics, and normally they just need to be used for around 10 days. So it's like normally enough time to make that endometrium microbiome like change. In case we need to use any specific treatment or any specific antibiotic, normally it's used for between 7 to 10 days, depending on the infection and depending also on the bacteria that is like affecting the endometrium. But I would say that normally between 2 weeks and maximum 3 weeks, it could be like time enough to make that endometrium be in the different condition and of course be improved for the next embryo transfer.
All right, excellent. Thank you so much. Once again, let me go to this question. So you clarified, you said the red part on the...
Gardnerella, exactly, Gardnerella.
All right, thank you so much for confirming. And let's go to the previous questions, okay? There are plenty of those. So after using antibiotics, is it necessary to check the bacteria again?
Exactly. It's also highly recommended to take another biopsy to confirm that the infection has gone and that the population of the bacillus, lactobacillus, is the one that we need. So we normally, after doing that treatment, we always recommend our patients do another endometrial biopsy so that we can confirm that the infection has been treated and has been solved, and also that the Lactobacilli species is like increasing and is doing fine. So it's highly recommended, of course. Yeah.
All right. Again, thank you so much. And how could we naturally reduce the NK cells?
Well, I don't know how to do it. So it's because it's part of the immune system. So it's like, it's not so, it's kind of a controversy regarding NK cells and immunology in general. But as far as I know, there are like no natural remedies to try to change that kind of cells. Of course, I'm sorry.
Okay, thank you, of course, for confirming. And one more on NK cells. Are we talking about NK cells in the blood or uterus?
Of course, we may talk about the blood NK cells and the uterus one, but I meant that the tests that are performed on the uterus just test the uterine NK cells. So you need to have that NK cells tested in general. You should also perform a blood test to know the exact level of that cells. But we were talking about just the endometrial test.
Okay, thank you once again for clarification. Okay, next one is up from Emily. What treatment options are available for patients with high NK cells and high cytokines?
Of course, it all will depend on the immunologist opinion, because depending on the patient's, the background of the patient, the previous treatments, and the NK cells level, and depending also on the immunologist, there are different treatments available. So if we are talking about, for example, when we test immunology specifically in the uterus, and we find that the NK cells are a bit high, in that kind of patient, normally what we recommend is a medication called Neupogen, which is like the granulocyte growth factor. And normally that kind of medication may help us in achieving pregnancy. But everything will depend on the immunologist, because that kind of treatment has to be recommended and by an immunologist. So we normally do not recommend that treatment unless our immunologist decides to do so. Of course, it's a very specific treatment and has to be prescribed for a very specific doctor.
Perfect, thank you. And let's have a look at the next question, okay? So there are a few questions from Tutsi, I believe. I'm not sure if I say it correctly. Excuse me for that, but let's have a look. Clexson, should it be started on embryo transfer day or a week before transfer?
Actually, it depends on two factors. First of all, is considering what kind of clotting alteration the patient has. And secondly, I would say that it also depends on the hematologist that has already prescribed the heparin. So in our experience, we normally recommend starting the heparin, the Clexson, like at least 1 week before the eventual embryo transfer, because apart from the anticoagulant effect that the heparin has, we also know that it can also like kind of modulate also the immune system, and it's also useful to use it like some days before the embryo transfer. Of course, it will depend also on the alteration the patient has, but in our experience, we normally recommend using it at least 1 week before the embryo transfer, unless the patient does not have any kind of a specific clotting issue, and the hematologist is also agrees with that. But normally, almost I would say that like more than 90% of patients start the heparin like some days before the embryo transfer. Exactly.
Okay, perfect. Thank you so much. And as I mentioned, next question from the same patient: assisted hatching, does it work on day 3?
Well, it's not a topic, but of course it depends on the embryo. So as we are not, well, at least in Clinica Tambre, we don't perform embryo transfer on day 3 anymore. So we always try to push the embryos to reach the blastocyst state. What it may work is, for example, if we need to do the PGS on the embryos on day 5, it's like easier for the embryos and for the technician who is performing the embryo biopsy to do like that assisted hatching, that is like doing like a small hole in the external part of the embryo to make the embryo like start like going out from that part, and it's gonna be like easier for the biologist to take some cells. Apart from that, there are some data that the embryo that have like that external part like quite thick, sometimes they have been found that it may help implantation, but it's quite controversial also. So as we do not perform transfer on day 3, we, in case the biologist recommend doing the assisted cutting, of course they just do it and it's fine, but we always do transfer on blastocyst stage on day 5.
Thank you so much for the clarification, even though it was a little bit off topic, of course, but still, thanks a lot. And let's have a look, okay? More questions are here. Up to how many weeks of pregnancy do you prescribe prednisolone, and up to how many weeks of pregnancy do you prescribe hydroxychloroquine, I think, sorry?
Yeah. Okay, so, well, as I mentioned before, it also depends on the immunologist, but what I can say is that normally we normally use prednisone, and it's used like from 1 week before the embryo transfer until week number 10 of pregnancy, normally. So after that moment, our immunologist recommends stopping it. And the hydroxychloroquine also depends on her. So I think that many patients start taking the hydroxychloroquine at least 1 month before the embryo transfer, and it's kept for the first week of pregnancy, depending on the alterations of the immune system and depending on the patient. Normally that kind of medication is like recommended to be stopped or kept some more weeks. So it all depends on the immunologist's opinion, of course.
And that makes perfect sense, of course. Thank you so much as well. Okay. And now intralipids. Okay, so is the treatment the same? What are your thoughts on intralipids and IVIG?
Well, at least in Spain, intralipids are not very used. So we normally prefer the intravenous immunoglobulin because the security profile is different. But of course, I'm not an immunologist, and our immunologist normally recommends using the intravenous immunoglobulins because the profile is like better and it's quite well known the effects it may have. Of course, the results are almost the same, and it all depends on the immunologist's opinion, not because this is not a medication that we normally prescribe. So it all depends on what she recommends to use in that kind of patient.
Okay, perfect. Thank you. And one more. At which cycle day is intralipid given at your clinic?
We don't use intralipids. We don't use them. But what I can tell that patient, Bianca, that in case we need to use the immunoglobulin, the intravenous immunoglobulin, we normally use the first dose before the embryo transfer, 1 day before the embryo transfer, or even the day of the embryo transfer. And then the second one is normally used the day of the pregnancy test, in case the pregnancy test is positive. Afterwards, the next infusions are used like every 3 or 4 weeks, depending on the patient, but normally it's like that way. So I'm sorry, but we don't use the intralipids.
Of course. Thank you. And again, similar question here, is IVIG better than intralipid?
I think that they are not like better or worse. It's like just a matter of like preferences and, well, of course, the experience that each immunologist has with each medication. So in the end, it's like, well, we know that the intravenous immunoglobulins are quite well sure to be used, but of course, that kind of medication has to be followed by a specialist. So in the end, each doctor prefers what they have been used to use in the end.
All right. Again, thank you so much. Let's have sorry, Kate has a follow-up actually. Does IVIG have many side effects? Many clinics don't prefer to use it.
Well, actually, in my experience, we have used it for many years and many patients, and we didn't find any side effect in any of the patients. Of course, each patient is different, but I think the profile, the security profile it has is quite high. So according to my experience, like everything went well, and I don't remember any patient that had any kind of side effect.
And sorry, there is one more. Who needs to treat with IVIG?
So actually, it depends on the patient's background and also on the immunological tests that normally are performed before recommending any treatment. So in general, patients with high NK cells in a blood sample are recommended to at least give that. Our immunologist gives the advice to be treated with that kind of immunoglobulins, and just in case, for example, the prednisone is not enough and the immune system can't be under control in that kind of patients.
Okay, excellent. Thank you so much, of course, as well for this one. Plenty of questions behind us already, but there are still more of those. So let's get to them. You are definitely on fire tonight, so I'm glad to have many questions. And let's have a look, of course, at the next question. So with high NK cells, will I have better chances to get pregnant, transferring to blastocysts, not PGS tested? Instead of 1, I am 35, and before discovering high NK, I have 2 single fade blastocyst transfers with receptive era and 8 millimeters triple lining.
Well, I think that in that patient, transferring to blastocyst embryos won't add any benefit in the end, because if the embryos were not tested, it's not a matter of like transferring one or more embryos. So if the endometrial lining was fine, the ERA test was also fine. Of course, if some specific treatment regarding the high NK cells could be added, or at least recommended, would be much better than transferring to embryos, because transferring to embryos won't add any, won't increase the pregnancy rate in that kind of patient. I wouldn't recommend doing that.
All right. Thank you also for that advice. And let's have a look, okay? We do have another question. Can Asper negatively affect implantation?
Well, if the aspirin has any effect, normally it's like it has a positive effect. So it's true that the aspirin may affect in a positive way of all that endometrium vascularity and all the flow that has to be from the vessels of the endometrium. So normally the aspirin could have at least no effect or a positive effect. I wouldn't say that it may have any negative effect. So we know that many patients could have a benefit using that aspirin, we normally recommend using it in patients that have previously been tested for some clotting alterations. So the idea is like just using treatments such as aspirin or heparin in patients that really need to use that kind of treatments. Because, for example, the aspirin, in case the patient gets pregnant, sometimes in a very small amount, but can go through the placenta. And of course, if it has to be used, it's fine. But if this is not useful for that patient, we do not recommend using it for all the patients at all.
Wonderful. Thank you so much. And actually, in regards to our previous question, it's again a question about transferring 2 embryos. Let's have a look, okay? So would you transfer 2 average blastocysts? Both have been PGT tested. I am 40.
I would never recommend a patient that has had previously their the embryos tested transferring to embryos. So that blastocyst embryos have, if they are healthy, they have high implantation rates. So the idea is that that patient gets pregnant and have a healthy pregnancy and a healthy baby at home. So transferring to embryos won't add any benefit apart from increasing the risk of having a twin pregnancy at all. So I would recommend just transferring 1 embryo for sure, 100% sure. I wouldn't recommend transferring 2 embryos. Never.
And thank you for that reassurance once again, of course. Thank you so much. And of course, there's a thank you from Sayuri for you for that. Okay.
You're welcome.
But some more questions are coming in, so let's have a look at this. What immune suppressant do you prescribe, recommend after 12 weeks of pregnancy?
Well, as I mentioned before, we do not add that kind of treatment because it has to be followed by the immunologist. And depending on the patient, some patients that have been using the intravenous immunoglobulins, they have to use them like all the pregnancy. And from week 10 on, it always depends on the immunologist. So as far as I know, she normally recommends stopping the prednisone by that moment. And depending on the patient, if she needs to take any other medication, is always recommended. According to her opinion, but as I mentioned before, this is not, we are gynecologists and we are not the ones that have to prescribe that kind of treatment. So of course, I guess that it depends on how the tests go and if how the NK cells and all the immunological system determination is doing, and of course how the pregnancy is doing also.
Wonderful. Thank you so much again for that. And the question here we have, would it make sense to treat any NK cells in cycles before the transfer cycle? If not, why?
Actually, what is recommended is when we need to use any specific treatment, it doesn't matter. I mean, in the endometrium, as we are talking this evening. So it's recommended to use it like as close as the next embryo transfer as possible. Okay, because the positive effect that we may find that patients, it's important to do the embryo transfer as soon as possible, because if the positive effect is there, like we need to do our best and we need to take advantage on that to try to do the treatment, the embryo transfer as soon as possible. Okay, so if it's possible to do 1 month the treatment and then the next month the embryo transfer, it would be like more than enough, and it would be like the best option in that case.
Great. Again, thank you so much. More questions are coming up. So is the endometrial scratch recommended for a patient with high level of uterine?
Actually, there is no data regarding if it's recommended in patients with high NK cells. What is known that in some specific patients, like doing that kind of a scratch on the endometrium, may try to activate the immune system, trying to afterwards have that of immune system more balanced after the next embryo transfer. But it's kind of controversy. It's there is much controversy on that topic also, because not all the papers have found the same results. So in general, our experience is that we had done the endometrial scratching in some patients, and we didn't find any changes regarding implantation. Of course, each patient is different, and each case there has to be like checked individually. But as far as I know, it's not like specifically recommended for that kind of patients.
All right, again, thank you so much. And let's have a look. Okay, more questions are coming up. And here's the next one from Jessica. For high NK cells and high lymphocytes, would you prescribe steroids or intralipid injections? Or
everything will depend on what we are talking about. If we are talking about like blood, high blood NK cells or lymphocytes, it's, as I mentioned before, could be treated according to our immunologist recommendation, maybe with prednisone or sometimes with immunoglobulins. So everything will depend on the specific patient and the specific case itself. If we are talking about the uterine, the endometrial NK cells, what is normally recommended is using that neupogen, which is like that granulocyte colony growth factor, to try to put that immune system in a balance. But of course, as I mentioned before, that kind of treatments are quite specific, and they are not like commonly used in the normal medical practice. So depending on the laboratory that is testing that kind of cells, they always recommend specific treatment depending on the uterine NK cells that they found in the sample, and depending also in the patient's background and that kind of things, because that kind of patients are so specific. That has to be like we need to have a really good approach of what to do with them in the end. So, we normally use that kind of medication. Yeah.
Okay, thank you so much. Let's have a look. Next question is up right here. Do you prescribe metformin to avoid miscarriages for women who are not PCOS and don't have insulin problems?
Normally, if of course they don't have any kind of issue regarding insulin, if they are not like overweight, we don't use the metformin in general. Just in cases of patients that actually need to use it, but not in general. No.
Okay, thank you. And is it bad to eat large doses of turmeric in food in the 2-week weight and beyond? Can they boost the immune system, cause miscarriages?
Well, as I would say that almost everything in our life, like a small doses of vitamins and so on, could be beneficial. Why not? But maybe a higher dose could be like, at least we don't know the effect it may have. So turmeric, we know it's a very powerful antioxidant. So taking some like small doses of it, of course, it may not have any effect, but in the end, taking a very high doses of, I would say that almost all the vitamins could cause an effect. We don't know if it could be negative or not, but I would recommend like having a healthy way of life during the 2 weeks after after the embryo transfer, and when you are waiting for the eventual pregnancy test. And I would try not to to change a lot the way we normally eat or take vitamins. So I would not recommend like using specifically high dose of nothing in the end.
All right, thank you for the clarification, of course, right here as well. Okay, let's have a look. Next question. Do you recommend adding lepresol to Bulcerelin for downregulation in the case of adenomyosis?
Well, it's like no topic, but it depends on the patients. So when we are talking about adenomyosis, we normally prefer to use the decapeptyl, which is like an agonist of the gonadotropin hormone, and during 3 months, because it has been like related to better pregnancy chances. So what we normally recommend is doing that way. So we don't normally use the letrozole at all.
Perfect. Thank you so much for the clarification. And do you prescribe Neupogen? Not sure here again, sorry.
Yeah, the Neupogen, well, it's normally prescribed by our immunologist, and it's just specifically used in very specific number of patients, and because it has to be really, that patient has to be under control due to some kind of alterations in the blood cell count and so on. But when CID recommends using it, of course we use it. Yeah.
And we do have a follow-up, okay, from our previous patient from previous question. So is the Decapeptyl better than Bulcerelin?
Well, the main issue with adenomyosis is that it's not so clear how it could be improved in the end, and how could we at least try to increase the implantation rate in that kind of patients. So we have kind of plenty of experience using the Decapeptyl. Actually, we have patients from that use the Decapeptyl due to the adenomyosis, and some of them got pregnant, of course, some others didn't. So in the end, it's very difficult to know exactly what's going on in the uterus in a patient with that kind of issue, but at least we have some data that helped us in deciding that maybe the Decapeptyl was quite useful for us. And actually, we, as I mentioned before, we used it in several patients and we got good results at all. But we don't know if it was like exactly just for the Decapeptyl, or it was that because it was like the moment for that patient to get pregnant.
All right. Again, thank you so much. And how about that question? Does the use of some medication affect the window of implantation? Can it be a like factor too?
Exactly. So it's a really good question. So we know that, of course, the hormonal medication could affect. So that's the reason why I mentioned before that it's really important to use exactly the same medication that we are going to use in the next embryo transfer. So it means that if we are doing, for example, a treatment with just estrogens and progesterone, we need to use exactly the same for the next embryo transfer. The same happens with the heparin. So the heparin is known that could affect, or at least is suspected to affect the window of implantation. So if a patient has to add heparin to the treatment due to any clotting alteration, we normally recommend using it also in doing when we do the ERA test, and also with the embryo transfer. So if the patient has to add the heparin, let's say like 1 week before the embryo transfer, we recommend using it also for the ERA test and then stopping it. And sorry, and regarding the age is not related to the window of implantation results. So it's not related in this moment.
Again, thank you for the clarification. And we do have another follow-up from Kate. Okay, so how frequent can you use the Decapeptyl? Do you need to wait a few months after using it first?
Well, I actually would recommend using it for 3 months, and we use 1 injection every month. And actually, after like stopping the Decapeptyl, you don't need to wait. So after the Decapeptyl effect ends, like 1 month after using the injection, the patient starts menstruating again, and in that moment we can start the protocol to prepare the uterus or whatever to do the eventual next embryo transfer.
Okay, perfect. And Kate has one more question. So does Clexson help women who have suffered several miscarriages?
Yeah, there is like quite like a high amount of data regarding heparin, Clexson, and other kind of heparin in general. So it's known that it may help patients, especially those that have been tested for several clotting alterations, such as thrombophilia or any other antiphospholipid syndrome and so on. So they normally need to use that, the Clexson or their heparin, trying to increase the implantation and the pregnancy rate. So in patients that have several miscarriages and that tested positive for that kind of alterations, of course, Clexson may help.
All right. Again, thank you so much, Kate, for your brilliant questions, that's for sure. And of course, Dr. Marbán, you are on fire for sure tonight. Thank you so much. And let's have a look. Kate has added one more. What protocols do you use for women with immunological issues?
Well, everything will depend on what kind of issue that patient has. If it's just maybe an alteration of the clotting, we normally add heparin or aspirin, and depending on the alterations that the immunological test show, sometimes if we need to add the prednisone or some other treatments, of course, it's always we follow our immunologist recommendation. So as I mentioned before, we are gynecologists, and we are not able to prescribe any kind of of prednisone or whatever, because it has to be prescribed by someone that actually knows exactly why they can be useful for.
Okay, perfect. Thank you so much. And one more question is right here. So how many months after laparoscopy do you need to wait for immune testing? I understand that laparoscopy can create inflammation and could distort the immune
system. Yeah. Well, actually, it will depend on what kind of laparoscopy and the reason to doing that. So if just like maybe the patient had, I don't know, a cyst, a benign cyst in the uterus, and it was like a laparoscopy to remove that cyst, it would be like not very important. But for example, if the patient had, I don't know, a surgery to remove an endometriosis cyst or whatever, of course, it could be like a more complicated surgery. So it's like recommended at least 1 month to do any kind of test in general, trying to make that also the immune system, all the body in the end, in the basal conditions, to start from the beginning to do the tests that are required.
Okay, great. Thank you so much. Okay, how about this follow-up? Okay. Sorry. Is it a laparoscopy to remove stage 2 endometriosis?
Yeah, I would recommend like 1 month and 1.5 months, approximately.
Okay, thank you once more for the clarification. What are the reasons for high NK cells count?
Well, in the end, it's just an immune system disbalance. So I think that, of course, there is it's very difficult to know exactly what's the reason why a patient has like that increase in the NK number cells number. So it's like impossible to know. So we know that the immune system is not working, or at least we suspect that it's not working as it should be, but nothing more. So it's impossible to know why a patient had or has that kind of alteration and why others haven't.
Perfect. Thank you so much. And if you can have a look at this short question, what is your immunological test?
It includes many immunological alterations, and we test thrombophilia, kill system. We test also for celiac. It's like it's a really long list of tests that normally request our patients, but everything will depend on the background. So not all the tests. The tests are needed for all the patients. So we try to, to focus in the ones that could be helpful for each patient. So it's not like doing immunological tests and that's all. No, we need to, to be focused, and we need to know exactly why are those tests gonna be useful for.
All right. Perfect. Thank you so much indeed. Okay. Let's have a look. It's regarding some while ago we had a question on prednisone. So what dose of prednisone are we talking about?
We normally use a prednisone, not prednisolone. So we use prednisone, and we talk about around 10 milligrams per day. So it's not very common to have a patient that takes more. Of course, it also depends on the body mass index and so on, but normally the most common dose is 10 milligrams.
All right. Thank you for the clarification. And okay, let's go to the last question, actually. So what is the difference between prednisone and prednisolone?
Like that, it's like there are two different types of steroids, and depending on the effect we want to have, and also depends on the experience that the doctor who is prescribing it has, is recommending one or the other. So in Spain, the most common one is the prednisone.
Okay, perfect. And let's have a look at the next question. Do you check ANA and anti-TPO as immunological tests?
Exactly. So actually the anti-TPO, which are the antibodies against the thyroid, we normally test them in the first consultation because it's quite common to find patients with some kind of thyroid issues, and we test directly to all the patients. And the ANA test is a very specific immunological test, and we request for it in patients with several miscarriages or failure of implantation. So it's one of the most common immunological tests that we normally do.
Wonderful. Again, thank you so much for that one. And let's have a look. Okay. So after immunological treatment at your clinic, what is the pregnancy rate?
Well, this question, it's almost impossible to be asked or to answer also because it's not just a matter of saying, okay, I'm going to add an immunological treatment and what's my pregnancy rate. No, because each patient is different. Not all the patients do exactly the same treatment. So what we have seen that patients that followed an immunological treatment, of course, if we are talking about egg donation treatment or testing the embryo for transferring, then of course the results are better. But I would like to clarify that not all the patients do the exact treatment. So if we are talking just in general, it's impossible to answer that question because we have seen that we improve, well, our results have been improved after the immunological treatment, but it's not just a matter of adding a specific treatment or not. It's a matter of like doing any other examination, as we mentioned before, regarding the ERA test in case it's needed, or like trying to do our best to have the best embryo to transfer and a healthy embryo also. So it's difficult to know exactly the pregnancy rate in each patient because each patient is different.
Of course, that makes perfect sense. Thank you so much for the clarification. Okay, let's have a look. We have a bit of a longer question from Emily. How does it work practically in the clinic if you have immunology issues? Do you see the gynecologist first to set the protocol and then have a separate consultation with the immunologist? Or does the gynecologist discuss the case behind the scenes only?
Okay, so we normally like recommend the patient that we have been like in touch before going to our immunologist consultation. Some tests could be required and requested for ourselves, and then in case the immunologist decides that some others could be also necessary, of course he will let the patients know. So we work like as a team, so it can be like both consultation could be almost at the same time. So we like check the immunological, like the gynecological part, and then of course our immunologist she will require the test that she recommends to each patient. Of course, she will add the specific treatment she will see things that could help that patient. But we work in a team, and of course she will be focused on her part, and we will be focused on ours. So in the end, we try to do like everything together, and of course we discuss patients, but the consultations are separate.
Amazing. Thank you so much once again, of course. Let's have a look. More questions are coming in. Having high NK cells and lympho detected by uterine biopsy, it means that also my blood should detect that. How usually these two values are correlated?
Well, the main issue with that kind of cells is that having that kind of cells high in blood doesn't mean that you would have them high in the uterus, and the same happens in the opposite situation. So if you have that NK cells high in the uterus, it doesn't mean that in general, like in the blood, would be exactly the same. So we know that that there are some cells that are just in the uterus and some others that are like circulating in blood, but it doesn't mean that they have to be related one to the others. So it's impossible to know in this moment how frequent is like having like both situations at the same time, because as I mentioned before, there is kind of a controversial topic, because not all the papers have found exactly the same situation in blood and in the uterus. So at first it was like just tested the blood uterine NK cells, but not uterine ones. And then they realized that maybe it was not the same situation in the uterus. And that's the reason why they started checking also the uterine NK cells. So we know that there have been to be NK cells in the uterus, but it's very difficult to know if you have like some cells, if it's fine, or if it's too much. So in the end, it's a very difficult situation to deal with, because well, it's very difficult to know exactly if the number of NK cells that patient may have in the uterus could have a negative effect in implantation, which in the end is what we need to know.
Amazing. Once again, perfect. Thank you so much, of course. And let's have a look. What immune suppressant do you prescribe? I think we already had that question.
I think so. I think so.
Sorry, I just clicked on that one once again. But let's have a look at the next one then. Is Prostab the same as the Capepto?
I don't know what's Prostab. I think that maybe it's a brand, and I think it's, well, actually it's not a Spanish brand of any treatment, so I can't say if it's exactly the same or not, because you know the Capepto is also a brand, so maybe it's not the same.
Understood, of course. Thank you so much. Okay, let's have a look. So how many months after laparoscopy? We also had that question, right?
Exactly.
Yes.
I think so.
Sorry, I'm not sure what's happening here. There are so many questions that I have to. Yeah, this one we didn't have yet. Do you have to use Clexson throughout the pregnancy after having suffered miscarriages?
Well, as I mentioned before, it will depend on the alteration that could be found in the tests. So if there is an a clotting alteration, normally it's prescribed for at least the first trimester, and depending on the patients and the previous miscarriages and so on, sometimes it has to be kept all the pregnancy long, and sometimes even after giving birth. So it's quite common that the patients have to follow that kind of treatment for all the pregnancy. Exactly.
Thank you for yet another question, and of course for your help with this. And can prednisolone and hydroxychloroquine, chloroquine exactly affect the
difficult word? As far as we know, as we mentioned before, it's true that the heparin may affect the implantation window, and it's the reason why we normally recommend adding it to the treatment in case the patient has to use it for any reason. But we do not normally recommend using prednisone or hydroxychloroquine because it's not known if it affects the window of implantation. So it's known that at least at the moment it doesn't affect the window of implantation, and that's the reason why we do not recommend using them in the patients that have been already recommended to use it at the embryo before doing the embryo transfer. So we just add the heparin in patients that normally have to use it, but not that kind of treatments.
Again, thank you so much indeed for yet another explanation. And this question is here: is celiac disease related to high NK cells?
Actually, it isn't. So there are like two different alterations in the immunological system. So it's known that the celiac disease may also affect the implantation rate and also the failure of implantation. So that's the reason why when we have to deal with a patient that has that failure of implantation, we always request to do for the celiac disease, to be sure that everything is fine in that way, because it's not like related to the high NK cells, but it's also a part of the immune system that has to be like in balance in case it's like not very well balanced.
All right. Amazing. Thank you so much. Let's have a look. Okay, we have a question on Neupogen. Can it cause any risk of inflammation, raise in uterine NK cells?
Actually, it would be like exactly the opposite. So in case the Neupogen has any effect, it will be like decrease that kind of cells in the uterus. That's the reason what is the treatment that is like most commonly used in patients that have that issue. So that Neupogen tries to to put the immune system in a balance, and it's not like it's exactly the opposite. So it doesn't help to increase the NK cells.
All right, thank you for the clarification. How about can it affect the ERA window?
There are no data regarding that, and it's not by the moment it's not related. So, and we do not recommend. We don't add that kind of treatment in the patient that are undergoing the ERA. So we just add the heparin because it's that we know that it may affect the implantation. But it's true that some patients, for example, that didn't use the heparin because they didn't know that they have to use it when they performed the ERA test, and of course we couldn't use it. We had exactly the same good results after using the ERA. So of course, if it's possible to know it in advance to add it, it's also fine, because we know that it may affect the gene expression. But in my experience, we had some patients that they didn't add the heparin before, and we had also good results in the end.
All right. Thank you once again. Okay, next question about celiac disease. Yes, we talked about that. What do you give as a treatment in case of celiac?
Well, we just removed some kind of food to the diet. So it's like having a gluten-free diet, and it's enough.
Yes, and actually there was a follow-up, yeah? If you are detected with celiac disease, what do you need to do? You confirm this gluten-free diet.
Exactly. Exactly.
Thank you so much, of course, for the clarification. And we have this question. Can you explain more about care and HLA compatibility?
Yeah, it's kind of a difficult topic to explain. So we know that there are some receptors in the NK cells, which are the KIR, and some others that are like in the embryo and some other parts of the uterus. So the idea is that some kind of patients may have a specific type of KIR receptor in the uterine NK cells, or actually in the general NK cells, that may, let's say, may be that patient has an increased risk of some adverse outcomes in the pregnancy, and also may have an increased rate of miscarriages or failure of implantation. So we know that the combination between the KIR AA and the HLA from the embryo, which is C2, C2 is like the most difficult combination between them. The reason is that we know that KIR AA makes that embryo to implant with lower chances, and apart from that, it's known that it's also related with some kind of pregnancy outcomes regarding preeclampsia, and also some other alterations during pregnancy. So in a very specific group of patients that have that immunological system issues, we normally test that KIR system in both, in the patient and in her partner. We normally recommend testing the HLA system to try to clarify if there is any kind of incompatibility between them. In case we find that kind of incompatibility, some specific treatments could be added. to the normal treatment to try to avoid any risks during pregnancy and try to reduce also the miscarriage rate. And regarding the last question, if the care system and the HLA of the father count, of course it counts. And as I mentioned before, we always test the HLA in the father, in the partner of the patient, and also in the patient. So as I mentioned also before, it's like that kind of test should be requested for the immunologist, because in case some alteration is found, it's very important to be like under a very specific treatment. And it's not just a matter of having a good or a bad care system or not. It's just a combination, because it's now known that some of them could affect negatively, or at least could increase them some kind of effect during pregnancy, while some other it's not affecting at all. But it doesn't happen all just with, for example, the KIR AA. Sometimes other patients with different KIR system could also have an increased risk of alterations during pregnancy, or even a lower pregnancy rate. So that's the reason why that kind of test should be requested in very specific patients, and also and always under the immunologist's recommendation, not just in general and for all the patients.
Perfect. Thank you so much. And we have 2 follow-ups, okay, from Kate. So let's get to them. What is the treatment for incomparability?
So it depends. If, for example, if we need to choose, if we have the chance of choosing like a donor with a specific HLA system, it would be like the best option, because many patients that are undergoing egg donation treatments, we are able to test also the HLA on the donors. Exactly. So, and they can also be tested for that kind of specific system. So we normally find a suitable donor for each patient. Some patients and many patients that have some KIR system issues, we normally need to select a specific HLA donor with, normally we use C1 donors, but we have other patients that, in contrast, they need C2 donors. So in the end, everything will depend on the combination. And our immunologist always recommends, in case we need to search for a very specific donor, to try to select a good donor also in the immunological way. And when we don't have the chance of selecting a donor because the patient is undergoing the treatment with their own eggs, normally some specific treatments such as Neupogen or sometimes Prednisone has to be used. So everything will depend on the exact alteration the patients may be found to carry, and in that situation, our immunologist recommends the specific treatment to follow.
All right. Again, thank you so much for explaining how it all works. And of course, Kate, for your follow-ups, that's for sure. Okay, and one more follow-up, this time from Polly. Would you get euploid blastocyst PGT if you were incompatible with HLA or KIR?
Exactly. So there are like 2 different issues and 2 different things. So when we talk about euploid blastocyst, it means that the embryo is healthy chromosomically. So we know that the chromosomes are fine. So it means that, for example, the embryo does not have any issue regarding, Down syndrome or some others, but it doesn't have anything to do with the KIR system. So when we test the embryos in a PGS or a PGT, we always make sure that the embryo is healthy in that way, so the chromosomes are fine, but it doesn't mean that the embryo will implant. So of course, one of the main reasons why the embryos don't implant is the embryo itself. But if the embryo is healthy, we know that we have like half of the way done, but we need to also have a good endometrial thickness and so on. So that it's not so easy as just having that perfect embryo. And also in some very specific kind of patients, sometimes the embryos has to be already tested by that for that kind of HLA system, which is a very, very specific treatment that it's very uncommon to be needed. But in general, they are like two different things. It's important to have a euploid embryo, of course, but it doesn't have anything to do with the care system of the embryo, or actually the HLA.
Again, thank you so much. And as you can see, there is a follow-up. Yes, is high NK cells count related to cure HLA incompatibility?
No, it's not like, it's like different. So we are talking just if we are testing the NK cells, it's just like the amount. And if we are testing the cure, it's like the receptors that cells have in the surface of the cell itself. So it's like it's not related. But what is true is that when we take advantage and when we do like very specific immunological tests, we prefer to do like all of them, not because they are related, because maybe, well, actually we know that they are not related, but it's just a matter of having like a complete examination on that patient and being sure that we have all that immune issues under control.
All right, perfect. Thank you. One more, okay, on that. For HLA, do you test DQ alpha or the complete HLA?
Well, we do like a complete HLA testing, yeah.
Okay.
And of course, as I have been saying before, it all depends on the immunological recommendation.
Of course. Thank you so much. We will change the topic a bit. There are two questions on vaccine. Okay, so let's have a look. So with regards to COVID vaccine, do you recommend waiting a certain amount of time before starting immune treatment?
Well, it's recommended at least by at this moment is waiting around 1 month to get pregnant, but there are no data regarding the immune treatment. So it's like it doesn't matter that it's like the COVID vaccine or some other vaccine. So I would recommend not using the like both treatments at the same time. So I would recommend like using the vaccination and then starting. It doesn't matter the treatment that you are following, but I would recommend like waiting around 1 month to start all the procedure to get pregnant, to try to, to have the immune system in the best conditions then.
Excellent. And as you can see, Kate has added, yes, should women undergoing fertility treatment not take COVID vaccine? What's your opinion?
I would recommend exactly the opposite. I would recommend getting the vaccine to everyone. So as I mentioned before, the vaccination now is like taking, if you are using the Pfizer vaccine, it takes like less than 1 month to have the complete vaccination protocol. So I would recommend to everyone getting the vaccine and then maybe waiting 1 month to start the treatment. So there are no data, if we are like talking about egg freezing, for example, that the vaccine could affect the egg quality or so on. So you can do everything more or less at the same time. But if we are talking about doing an eventual embryo transfer, we might recommend waiting until the complete vaccination protocol has been done.
Okay, thank you, of course, for the clarification to this one as well. Jessica has added, I did in Spain a biopsy endometrial con cellulas. You can see it.
A mixture between.
Exactly. I will not read it. You can see it, of course. So does it count for my tumor?
Okay, so well, it's different because the microbiome is the totality of bacteria. So the plasmatic cells may count because we know that when we are talking about infection, it's quite common to have that kind of cells in a high amount in the endometrium. So it's quite related, the infection, to that kind of plasmatic cells. But if we want to clarify exactly the species and the bacteria we have inside the uterus, it's important to ask for it. Otherwise, if we know that we have no, for example, plasmatic cells over, in case the plasmatic cells are high, it just makes us suspect that maybe that patient may have an infection. But we need, first of all, to clarify what kind of infection is in that patient affecting, or apart from that, if the amount of lactobacilli species that patient has is the normal one. So it's like it's a different test to be requested.
Thank you. And let's have a look. Okay, of course, there is one more. There are a few questions left. Okay, we will be slowly finishing. But let's have a look at this one. So, did we have that question as well? Sorry, I believe so. Let me go to the next one. Yeah, is it true that someone who never had a third trimester pregnancy will have low LAD?
LAD.
Yes, I'm not sure here either.
I don't know what she refers to.
Of course, if you can just
Maybe,
clarify what you
yeah, it would be great if she could clarify.
Go back. Yeah, leukocyte activation. Yes.
No, it's not related. No.
Okay. Perfect. Thank you for the confirmation and, of course, for the clarification. Let's have a look. Next question. Can stimulation after result of thyroid antibody testing?
The stimulation. No, so we know that the stimulation itself doesn't affect the antibodies that we can find in blood. So what we know is that the TSH, the thyroid function, could be slightly altered due to the stimulation, not the stimulation itself. I mean, it's like more the hormonal medication and the hormonal like balance that could affect also the thyroid, because the thyroid hormones and also the ovarian hormones are quite related one to the others. So the stimulation itself won't affect the antibodies, because antibodies is like it's not related to the stimulation. So if a patient has like negative antibodies, it's fine. But if they have like that antibodies that tested positive, we need to take care and be like really careful with the TSH level, because we know that TSH can vary a lot during the stimulation, especially in patients with positive antibodies.
Fantastic. Again, thank you so much indeed. Let's have a look. Okay, next question. Regarding the uterine NK test, do you do it with the Chicago lab or with Matrice lab from France?
I would, to be honest, we don't use any of those ones. So we work with a Spanish laboratory, and we have done several tests with them, and well, we are using that test.
Of course. Thank you so much for the question, though. Definitely interesting, and thank you as well. And can MTHFR mutation cause implantation failure? How do you treat patients with these mutations?
Well, that kind of mutation is really common to be found in general population. So we know that around 50% of people may have that alteration, that kind of thrombophilia mutation. So having just that mutation is not related to any, implantation failure or to miscarriages in general. But if we have a patient that had previous miscarriages or had previous implantations, a failure of implantation, it's important to consider it. So in case we just find that alteration, we normally add folic acid, which is the first line option. And then in some patients, normally it's needed to be added heparin or even heparin and aspirin. So it's the most common treatment to follow.
Okay, perfect. And let's have a look. Okay, Jessica has added, I was suggested to go for a downregulation injection the 21st day of the previous cycle before embryo transfer to have a positive effect due to high NK cells. Would you agree with that?
Well, I would need to know a little bit about the patients, but in general, the main issue with that kind of treatment is it's not so easy to give like a, let's say, like a high evidence regarding some kind of treatments. So in general, some immunological treatments are used and we have good results, but it's difficult to know exactly if in that patient we will have such results. So it's very difficult for me to give an advice to that patient, because of course I would need to have much more about her.
And again, that makes perfect sense. And of course, in a minute, I will send you like a link where you can definitely ask more questions. And of course, you can provide more details to Dr. Marbán and her team at Tambre. And I'm sure they will be happy to get back to you with some more details as well. Okay, let's have a look. We will be finishing. There are like 4 questions left. So I guess that will be it. And from what level of TPO antibodies do you consider there is an immune issue?
Actually, it depends on the laboratory that performs the test because the range may vary between laboratories. So if they are like positive for that laboratory, it doesn't mean that it's like a very strong immune issue. It's just a matter that we know that antibodies are positive and we need to take care of that patient's thyroid function because they are at risk of having some alterations in the TSH level, and it's important to have the TSH under control as much as we can. Otherwise, we may find some problems afterwards. So it's not a matter of how high that thyroid antibodies are. It's just a matter of saying, okay, they are positive for the laboratory or they aren't. If they are positive, we need to take care about the TSH level.
Thank you so much for that. And Kate has added one more question. Are there any side effects of using estrogens in several fertility treatments?
Well, if the period of time that they are used is short, I would say that, of course, the estrogens have, as all the medication, all the hormones have some side effects, but the most common ones are like headache and like some kind of a slight belly pain and so on. But the effects they have, the side effects are not very common, and of course they are not very severe. But all the medication may have that side effects, so we need to be ready to try to use the medication just when we need to use those, that kind of treatment. So we have much experience in patients that have to undergo several treatments and they have been using the estrogens for like several times, several months, and we didn't find any severe side effects in that patient. But of course, the less the better in the end. So we are talking about hormones, we are talking about medication. So if it's possible to achieve like good results in 2 months, it's better than using them for 10 months, of course.
All right. Again, thank you. And one more, could stimulation affect liver values?
Well, I would say yes, because, the medication, it doesn't matter what kind of medication we are using, but most of the drugs we use have to be like, they go directly to the blood, and the liver is the organ that will clean that blood from that kind of issues. So sometimes if some patients are like more sensitive for some kind of treatments may have that liver values a little bit higher. So we don't see it very commonly, but sometimes I have seen patients with an increase on the liver enzymes after doing the treatment or after using some specific medication. Normally, when we stop it, the liver function goes back to the normal situation and to the previous situation, and nothing important happens. But it's sometimes it can be seen with all the medication at all.
Okay, thank you. One more. Okay, can medication stimulation cause high bilirubin? Sorry.
Actually, it's not very common. So some patients have like a slight increase in the bilirubin levels, and it's something quite common to find, especially in young patients. So it's something called the Gilbert syndrome, which is like quite typically to be found in patients. So we just see like a slight increase of the bilirubin, but it doesn't affect at all the patients and it doesn't have any negative effect. But in the end, as I mentioned before, when we're talking about hormones and medication in general, some parts of the body could be also affected by the medication we are using. So in general, the stimulation does not affect the bilirubin level, but of course, it could affect in some patients. Why not?
Okay, perfect. Thank you so much. And about letrozole, is it helpful in case of endometriosis?
Well, there are some data regarding letrozole and those kind of treatment that could like try to decrease the estrogen levels that could affect negatively to endometriosis. So, of course, it could be helpful. In the end, sometimes endometriosis is a very difficult illness to deal with, and there are many treatments that have been tested to try to improve the results regarding fertility and also to improve, the normal and the daily conditions of the patient. So, of course, it could be also helpful. Yeah.
All right, perfect. Thank you so much. And well, I believe this will be our final question for tonight. However, I have just sent you a link. There is an option for you to get in touch with Dr. Marbán and her team at Clinica Tambre, and I am sure they will be more than happy to help you out. Okay. And the question is, so how often do you test the TSH after transfer for a patient with positive antibodies?
Actually, we test it before the embryo transfer. So if she has positive antibodies, at least like when she's starting the preparation for an eventual frozen embryo transfer, or even if the patient is like starting the stimulation, normally we recommend testing it in that moment, trying to be sure that TSH is fine. And after doing the embryo transfer, depending on how on the patient, we normally test again the TSH with a pregnancy test at the same time. If the pregnancy test is positive and if the TSH is fine, we recommend testing it like maybe like 2 weeks afterwards, trying to like have that patient under control and trying to do our best in that way.
Fantastic. Thank you so much. And okay, one follow-up. Okay, and after?
After the embryo transfer, we normally recommend doing it once we do the pregnancy test in blood with the when you do it, and if it's fine, sometimes after 2 weeks. That it normally takes place at the same time as the first vaginal scan that we do we do the first vaginal scan in the consultation. And depending on the patients, we don't normally perform all the pregnancy follow-up. So if that first TSH is fine, we normally recommend like testing it every at least it's has to be tested in all the trimesters during pregnancy, but in that kind of patients, it has to be tested like more closer, as we need that they have that risk of having that TSH a bit high.
Excellent. Thank you so much. And as I mentioned, that was our final question. So I would like to say thank you so much, everyone. You've been amazing with those questions tonight. Very, very detailed question, but also wonderful. It's wonderful to see that you are so engaged and asking. And of course, what can I say? Dr. Marbán, you have been fantastic today. We had lots and lots of questions. It's like almost 2 hours now. So thank you so much for your time, for explaining all those details. Even if the questions sometimes were off topic, you were amazing with answering all of them. And as you can see already, Kate, thank you for answering all my questions.
You're welcome. It was a pleasure for me.
It's been a great session. So thanks to you as well, because of course, without your questions, as you know, it would be probably quite, we wouldn't be here really. So thank you so much for joining us and staying for almost 2 hours. I know that some of you didn't leave the room for a minute, I think even. So thank you so much. It's definitely amazing. And Dr. Marbán, as you can see yourself, there are some comments here. This has been very useful and informative. And we are very happy to hear that, because that's why we are here. So thank you so much indeed. Anything else you would like to add before we finish?
And I'm really, really glad to have so many questions. I know that the topic was really interesting, and I hope that everyone has been able to ask their questions. And I hope that my answer has been able to clarify all their questions. And I hope that they are happy with the topic and also with the question they asked. And it was a pleasure for me to.
Doubt that it's been useful, and definitely it's like this. I mean, we had webinars with you before, and it's always great to have you here, as you know. So till our next event, that's for sure.
Thank you.
And of course, I just want to mention that if anyone had to leave for a minute, don't worry, you will be able to find this on our site tomorrow. It will be available on my IVF Answers, but also on our YouTube channel. So you will be able to have a look at this once again. And thank you, because I think that Dr. Marbán, you have been questioned thoroughly today. So it's amazing. Thank you so much. And
you're very welcome. It has been a pleasure for me.
Have a lovely evening or night wherever you are, or day wherever you are. So thank you so much. And Dr. Marbán, till our next event, okay? I'm sure that we are going to have some more. So thanks a lot.
Thank you.
Take care, everyone.
Thank you.
And of course, I hope to see you back here tomorrow at 8 p.m. We will be back with some other topics. So if you haven't signed up yet, go ahead and do it. Thank you so much. Take care. Bye.
Bye-bye.